Good evening, friends. Welcome to the second session of the discussion of the slip disc or the PIVD or the disc herniation or the sciatica. So, we are going to continue our discussion further. Last week, we basically did discuss a bit of the basics of why it happens, what is the nomenclature, why posterolateral is most common. So, whenever it happens now, what is the symptomatology? Slip disc, as we understand, is the most commonest entity in the lumbar spine. So as per the affection of the nerve root, you get the symptoms accordingly. So basically, if ever there is a compression of the L1 root in this first image that you see over here, there is pain and there are symptoms around the area of the inguinal ligament. Similarly, when we talk about the L2 compression, it is below the area of the inguinal ligament and is restricted to above knee. I would rather say, if we talk about above knee, it is in the upper part of the thigh. It is not even just above the knee. Because if you see in this particular third image over here, when we talk about L3, that is a major area where, the symptoms are just above the knee, wherein there is a compression of the L3 nerve root that is involved. Whenever we talk about L4, it is the area below the knee on the medial aspect, and also I will say on the front, on the shin. L5 similarly is the lateral aspect of the lower leg, and S1 is the posterior aspect or the calf. So generally, this is how the symptoms are with respect to the dermatomes and the compression. Now, whenever the patient comes to you with acute disc, if ever it is, decently big in size, compressing on the root, the patient presents to you possibly with a forward bent and also bent on the side. This is basically the sciatic list. Why does it happen? It happens so that it is basically a defense mechanism of the body, you can put it, so that the body takes you away from the area of the compression. And that is why the patients are bent like this and they have a list. So now when we talk about the neurological involvement, there are different tests you have to do. But basically what we are going to talk here about is L4, L5 and S1 because these are the main key muscles that may be involved with this compression. So L4 as we discussed, when we talk about the dermatome, where exactly the pain is going to be, it is on the anterior aspect of the shin and the medial aspect of the leg. You check for the ankle dorsiflexus. In chronic cases, there may be quadriceps wasting also associated. And also, in some cases, the knee reflex may be altered. So, these are the main things that you see wherein there is an involvement of the L4. Where there is an involvement of the L5, you basically will have an affection of the great toe dorsiflexus. So, great toe dorsiflexus will not work properly. Along with this, you have to check for abductors because abductors are another muscle which are supplied by L5 and they are very important with respect to decision making because if the patient just has weakness of the great toe dorsiflexus, we are not that much worried as compared to if the patient has got a weakness of the abductors. Similarly, when we talk about the dermatome or the area of pain, the pain comes on the lateral aspect of the leg. Whenever we test these patients, we ask them to walk on their heels so that we understand whether there is any deficit or not. S1, so the pain is basically in the posterior aspect of the calf. These patients basically what we try to test for is the ankle plantar flexus. If in severe cases, the ankle jerk may also be involved and affected and or altered. Along with this, some cases do present to us with the gastrocnemius and soleus muscle weakness. There would be a wasting that may be associated, which may be noticed on comparison with the opposite leg. In these patients, the main thing that happens is the toe walking is affected and they are not able to walk on toes. So this is something that happens in the affection of the S1 nerve root. So I'm going to repeat over here. L4 ankle dorsiflexus, pain is on the medial aspect of the shin. Severe cases, quadriceps wasting may be there, and along with that, the knee jerk may be altered. L5, greatodorsiflexus abductors. The pain is on the lateral aspect of the leg, and walking on heels is generally difficult. S1, ankle plantar flexors are affected. The pain is in the calf area, and the gastrocnemius and soleus muscle may be affected. There may be wasting in chronic cases. Along with that, the ankle jerk is affected. Now, this is what I was talking about. This is the sciatic list. Whenever the patient basically has this compression in the spine, the body, as a defense mechanism, tries to take you away from the site of compression. So generally, wherein the patients are having a shoulder disc. So basically, remember, see, this is the spinal cord, this is nerve root that is coming out. Spinal cord, nerve root. Whenever there is a disc that protrudes out and is present in between the nerve root and the spinal cord. So this is the axillary disc, and wherein the disc is lateral to the nerve root, that is a shoulder type of disc. So now, my friends, whenever there is an affection, as like if there is a shoulder type of disc herniation, the body bends on the opposite side of the disc herniation. So, for example, if the patient is having a shoulder type of disc herniation on the right side, the body will bend towards the left. And similarly, if there is an axillary disc compression, as we see in this particular image over here, the body is bent towards the site of herniation. So, for example, if the patient is having a right-sided axillary disc, the body will bend on the right side. Now, whenever we talk about a central type of disc herniation, I'm now going to talk about features basically of the specific type of disc. Central disc generally is associated with back pain only, and these are the most notorious discs, and these patients may present to us with a cauda equina syndrome, which is a surgical emergency. We are going to discuss about cauda equina in the subsequent sessions. So, central type of disc herniation, these patients may present to you with a discogenic back pain only without any radicular pain. In severe cases, they may present to you with bilateral radicular pain. Posterolateral type of disc herniation, it is the most commonest type of disc herniation. It is as common as 90 to 95% of the cases. The posterior longitudinal ligament is the weakest over here. As we discussed in the last session, wherein this is the area where the ligaments are the most weakest, and that is the reason why it is an area where it is commonly given away by the slip disc. It affects the traversing, the descending, or the lower nerve root. At L4 and L5, it may affect the L5 nerve root. So remember, my friends, it affects basically the traversing root. So wherever this type of posterolateral disc is, it will affect the traversing root. So at L4 and L5, the traversing root is L5, and that is the reason why L5 will be affected. Foraminal type of disc herniations are less common. They occur in 5 to 10% of the cases. They basically affect the exiting root or the upper nerve root. So at the area of L4 and L5, if you have a foraminal type of disc herniation, that is just going to cause the compression of the L4 nerve root and symptomatology of the L4 nerve root only. So I'm repeating, a posterolateral disc herniation will affect the traversing root, and a foraminal type of disc herniation will affect the exiting root. So if ever we talk about L4 and L5, if ever there is a foraminal disc, the exiting root will involve and its L4 will be involved. And if ever there is a posterior central type of a disc, at L4 and L5, the traversing root will be involved, and that is the L5 root will be involved. Axillary type of disc herniation, they can affect both the exiting as well as the descending roots, and the patient presents in severe pain. Now, why does this particular disc affect both? So if ever you see this image over here, this is the axillary disc, the last image. So as you see over here, this is a prolapsed disc material which has come out from the axilla, and if it is big in size, it will obviously cause the compression of this particular exiting root as well as the compression of this traversing root. So obviously, if ever this axillary disc is big in size, so it is notorious to cause symptoms of both, and it may just not be restricted to one. And if ever this happens, like the axillary disc, which is big in size, affecting both the nerve roots, so generally these patients have severe pain. Now, when we talk about the test for diagnosis, so basically you have to elicit all the nerve root tension signs. So the first is the straight leg raising test, wherein you have to keep one of your hands below the sole The other hand should ensure that the knee is straight and it is not flexed. Try to straighten it if the patient keeps it flexed. If ever there is pain, that means the test is positive. Crossed SLRT, basically doing eliciting the SLRT on the opposite side. If ever the patient, for example, has symptomatology as shown over here on the left side, and you try and elicit the straight leg raising test on the right side, the patient will get pain on the left. So the one important thing over here is crossed SLRT is the most specific test for a disc cause of a radiating pain. So if the patient is having a radiating pain and the crossed SLRT is positive, the most common etiology may be a slip disc. Lasegue's sign. Lasegue's sign is basically one step ahead of straight leg raising test, wherein you elicit straight leg raising test. After you do that, the patient gets pain. Once the patient gets pain, decrease the angle of the leg. For example, once you did a straight leg raising test and you got a test positive at 60 degrees, get the leg back to 50 degrees. After you decrease the angle, the patient will feel better. Now the final thing that you will do is you dorsiflex forcefully the feet. Once you dorsiflex the feet forcefully, the patient will have pain. There will be an increase in pain, which is basically confirming the nerve root compression. So straight leg raising test, crossed SLRT, and the Lasegue sign. Provocative test, as we discussed, straight leg raising test. The technique is most commonly supine. It can also be done in sitting position, wherein you try to elicit the straight leg raising when the patient is sitting. The most test, this test is mostly specific in between 30 and 70 degrees of hip flexion. It reproduces the pain and the paresthesia in the leg. When we talk about the sensitivity and specificity, it is decently sensitive. However, the specificity of the crossed SLRT is better. It is the most important and predictive physical finding for identifying who is a good candidate for surgery. So this is generally something that is not required at this your level, but basically the patients who are having pain and they have provocative test positive. So the results of surgery will be good in these patients as against those patients in whom the pain is there, but the provocative tests are negative. Contralateral SLR or crossed SLRT, wherein as you lift the opposite sided leg, the patient will have pain in the ipsilateral side. So this is less sensitive but more specific test for a discogenic cause of a radiating pain. Lasegue's test, as we discussed, we basically supplement SLRT with forced ankle dorsiflexion after we decrease the angle of the straight leg raising test. So, for example, if the straight leg raising test is positive at 70, first you reduce the angle to 60, dorsiflex and elicit the test. Bowstring sign, wherein the SLRT is associated along with a compression on the popliteal fossa. So, as you see over here, this particular patient is sitting with one of the legs on the examiner. We basically try and elicit pressure on the popliteal fossa. If ever the pain aggravates, that means that the patient is having nerve root compression. Now, my friends, this brings us to the end of the discussion today. Further, we are going to discuss on slip disc in the next session. Thank you.